Interventional and technological innovation.
Hi, good afternoon and welcome here to our panel. I'm Jessica SCHEMBRI Higgins, a higher specialist trainee in general surgery. It is definitely an exciting time to be a trainee. Hearing these talks this morning have filled us with hope and enthusiasm for the future. And I would like to extend a very warm welcome to this fabulous panel over here and would like to invite the panel to introduce themselves and tell us quickly something about their backgrounds.
Professor Michael Griffin, esophagogastric cancer surgeon, past president of the Royal College of Surgeons of Edinburgh.
I'm Philip Taylor. I was professor of fixed and removable prosthodontics at Queen Mary, University of London, consultant in restorative dentistry, and I'm the immediate past dean of the Faculty of Dental Surgery of the Royal College of Surgeons of Edinburgh.
My name is DALLI. I'm a general surgeon trained in the Malta. I'm currently working as an oncoplastic fellow in Sheffield, and I have a research interest in surgical AI.
Good afternoon. I'm Kieran, CHIRCOP. I'm an interventional radiologist working in Malta, and as I'm sure you know, interventional radiologists have a lot of toys at their disposal. Thank you, and I'll be happy to contribute.
Thank you. I'm Manish Chand. I'm a robotic colorectal cancer surgeon from University College London and a tenured academic with a lab that investigates and researches surgical technology.
So innovation and technology have transformed healthcare in an unprecedented fashion recently, allowing for new opportunity to improve healthcare outcomes and also to enhance efficiency, reduce costs, and also better our performance. So going on that and riding on the wave of the trainees, I see a lot of my fellow trainees here in the audience. Professor Griffin, you mentioned the model of adapting robotic-assisted surgical training. What would your recommendations be here? There's our clinical chairperson and deputy chairperson in the audience in implementing such a surgical training program locally in Malta.
Well, as I said in my talk, the most important thing is that you start all the trainees early. In other words, in core surgical training, they have to have the facility to go to clinical skills laboratories, to have hands-on experience, to learn all about the technology of the robot. Our experience has largely been with the Da Vinci, but there are other robotic firms, CMR, Cambridge Medical, but these courses have to be available at the very start of surgical training. Just when you're learning to do appendixes and abscesses, there needs to be the experience of learning about the technology of the robot. And then you develop that through surgical training such that it is introduced then on straightforward cases and you move on to the clinical environment. And as I said then, the more complex work, again, needs to be done in simulation before it is started in less complex cases in the clinical environment. Absolutely key that the technology is understood by all of our junior trainees.
So essentially we are scrapping the old adage of a see one, do one and teach one mentality, and we're moving more towards safer training, which Prof. Chand has actually mentioned in his talk. Would you like to elaborate on that?
I think in this day and age, it's not appropriate, quite rightly, to have that adage of that you just mentioned, where we learn experientially rather than learn by being taught by someone through an apprenticeship, where there's structured training, reproducible training, and we look at the metrics of that training to see where we're doing well and encourage where we're doing well, and where perhaps we can improve. And a lot of the articles that I write and research that I do is trying to leverage ideas from other industry, in particular sports, when it comes to coaching. We don't really have a coaching culture in surgery, certainly not a structured one. And then also using technologies from You know, my job is to take something that Tesla does and put that in healthcare. I'm not inventing the wheel or reinventing the wheel. I want to take technology from Amazon and put it into healthcare and do that in a way that affects our patients in a way that everyone can use it. Because an innovation is not an innovation unless everyone has access to it. So it shouldn't just be in the ivory towers. It needs to be in every hospital, in every country, and accessible to everyone.
So essentially, innovation is what we should all be striving for in our departments. It is not just about providing a service provision, but also fostering and this culture and this mentality of innovation. Mr. Dalli, I know you've been working on some projects involving AI in surgery. Can you tell us a bit about your personal challenges and your past experiences in trying to develop these innovative techniques?
Obviously we've heard from the user end, the surgeons using the robots and the tools, and hopefully AI at one point, but there's obviously a backstory and people trying to develop these tools. For the past 3 years, I've been working as a surgical researcher, essentially. I'm trying to develop these tools. The key challenges we have is advancing surgery very rapidly. People talk about Tesla and Amazon. Overall, I think in surgery, we're still a generation behind this. We're still struggling with digitalization. You speak to people everywhere in the world. I've worked in the UK, Ireland, and Malta. The challenges are the same. We're still struggling to get databases, to get our patient data into computerized records, to join up all these records, because very often different departments, different sections are computerizing at different speeds. So even though we have systems, they're not talking to each other. From my end, the challenge is more sort of mundane, trying to access this data. Once the data is there, we can start to innovate. The tools nowadays are available, but there is, again, also this new flashy toy mentality. AI is the new toy surgeons want to play with. Everyone wants to try AI. It can be very dangerous. We've seen from ChatGPT, which is commercially available, that its performance has changed now from when it was launched, with regard to certain functions actually degraded. These sort of things are not acceptable in surgery, and the EU, for example, has made it very clear that medical devices which involve AI have a degradation threshold. If the AI learns the wrong lessons, it will be pulled off the market. The FDA, on the other hand, is taking a different approach, is embracing this learning in a more controlled way. So I think, as is the key theme of this whole talk, that the technologies are there. We do have a lot of work to do in healthcare, but we should also be cautious. What is happening at Tesla, what is happening on your phone, on your Android phone, is not necessarily applicable to surgery, because we need more time and more patients to get these tools working safely in our patient care.
So, Dr. Kirkhope, Mr. Dalli actually mentioned about interdisciplinary teamwork. You come from the background of interventional radiology, and you've been working with minimally invasive procedures as well. What's been your experience with regards to developing AI, using digital health, and actually working with other departments, such as the surgical department, and trying, to bring this forward?
So, from an AI point of view, radiology is a little bit more advanced. For example, locally, we're introducing an AI software to report chest X-rays. Now, FDA, the European Commission have all different views, but for example, FDA approved there are at least 10 softwares that can semi-independently report, and at least one software which is licensed for completely independent chest X-ray reporting. Locally, there has been a bit of a challenge, like there has been everywhere, where people view AI as something that will replace them, whilst others, and I'm with this second group, that will see it as an extra tool, an extra pair of eyes. Sometimes you don't have the luxury of having a second radiologist reading your report, but you have now the luxury of being able to buy AI to replace that second person, especially in a busy on-call shift, where prioritization of the most dangerous scans is a priority. So we're introducing AI with regards to diagnosis, but also with our streamlining of work, and hopefully very, very soon, we'll also be introducing into our system management. The doctor part of the job is only one. It's only a small part of it. There's a lot of background work, like Jeffrey was mentioning, that happens by other non-medical people. And if we can streamline that, it would make the whole process of patient referral to diagnosis much faster.
In fact, we've had some earlier talks this morning that actually focus on the role of AI in radiology and actually being the second screener, such as in mammography screening and screening programs. So that does take away from the doctor workload, let's say, especially on a system that is already quite strained and short on doctors and nurses. So we have mentioned a few challenges and barriers towards adapting this innovation and technology in our everyday practice. We've mentioned the lack of centralized data, of everything being digitalized, of all patients' records being there, the teamwork that needs to be involved, working with other disciplines, and also at the very core of all this, patient safety, which should be paramount to all of our every new step, every new development that we do. So, Professor Taylor, tying to your talk earlier today about this, how would you actually advise us, how would you guide us in overcoming these sort of challenges?
I think we've got to sit down together and talk about it. I think this is where a lot of the problems lie, is that things are being done in isolation. It depends on what you call innovation as well, doesn't it? Because innovation should be something that happens every day. I kind of think that if you go to work and you've not been uncomfortable that day, you've not actually had a good day's work, because you need to be starting to think about what happened, what could I do better. Every day something should be better. You don't need a new toy to do it better. You should be able to try to do something better. And I think one of the things that is quite important that I didn't mention, but I think is something that we do need to think about, is if you are an early adopter and you're very keen to get the new piece of equipment, is that the right thing to do? And a sort of the analogy would be the colour television, isn't it? So I don't understand why I'm going to be watching the World Cup and my wife hasn't allowed me to buy the 95-inch OLED Samsung TV. It's beyond my comprehension why she's not allowed that. But of course, if she did allow me to buy it, next year, that would be old hat. So the problem that you've got is that if you're an early adopter, you buy something that's the early part of the equipment's out of date fairly quickly, even the software's out of date. What do? So one of the options might be, and this is facing the reality of the world, you could lease it. So leasing allows you to send it back and you could do some, but the majority of funders, particularly public health funding, won't allow you to do leasing because it's so expensive. So that's one of the barriers that we actually face in providing new technology. And I think that's something we need to look at. And so maybe we need to be sitting down with the technology companies and saying, yes, you've invented this. Yes, it's cost you a lot of money to get that onto the market. But how can we help you recoup your costs by some sort of staging of the payments for that equipment as it's installed into a hospital or wherever?
So essentially, as the healthcare providers, we are both the advocate for the patient. So we are what stands in between, protecting the patient from potential harm from this new technology, while at the same time also being the dreamers that bring this idea home. Let me put another question to the panel. So this digital health and AI, is it another tool in our armamentarium, or do you think there may come a time where it will affect our critical thinking and we will become more reliant on this new technology to actually make our decisions? Are we going to become worse decision thinkers because of this, or better ones?
If I can join this conversation, I think this is always a problem we have when we're introducing something new in medicine, for example, in surgery. So when we have a new device that removes the cognitive load from the actual operator, the fear we have is that our newer generation of surgeons actually get lazy. And when these systems fail, they can't sort of sort things out. So, for example, with regard to the robot or with regard to any advances, you get so used to using these new tools, and there will be a day when the robot doesn't work. The machine breaks, or for some reason you can't use it, and you have to fall back on your previous training from a time when these things were not available. this is a training issue, and especially when it comes now to AI, where we're going to see these tools enter our decision-making roles. So, for example, currently their scope is very limited, but for example, one of the big openings for software is to replace surgeons when it comes to taking decisions based on multiple sources of information, what we call the MDT, the multidisciplinary team meeting. So there'll be a point when the AI can weigh up all the input from the radiology, from the pathology, from the surgeon, and take a decision themselves. The fear is then, obviously, that the surgeon's decision-making skills are going to become redundant. This is a challenge, and, you know, it's always, the old guard would always say that, you know, the young guard have it easy, you know, it's always getting easier. It's a reality, but in the end, you know, we have the information, people can go back and retrain. But undoubtedly, yes, as software and as tools remove roles from the operator, the newer generation or even the older generation might forget these skills. So yes, undoubtedly that is a major issue.
Okay, yeah?
Yeah, I think the other thing to add to that, of course, is that if you are going to have innovation and you become dependent on technology, then you're unlikely to think outside the box for that next bit of regeneration or that new type of surgery, and you're not going to be able to think of that. It's not just a lack of knowledge, but it's just being frightened that you're challenging the technology that is almost ruling your decision making. I think particularly in radiology, that's a really big danger.
I mean, the key thing here is not stifling innovation. The problem with healthcare is that at the end of the line is the patient. And we have to be, because we are one of those patients. Increasingly, as I get older, I'm going to be one of those patients. And I certainly want to make sure that the individual or the team that are looking after me are able to deal with every aspect of a complication that will happen. And you were very rightly bringing up the idea that, and it happened with minimally invasive surgery, with gallbladder surgery, laparoscopic cholecystectomy. We've come to a stage where trainees have never seen an open cholecystectomy when something goes horribly wrong. And it can happen. Now, they're being brought up to manage many of those complications in the laparoscopic environment rather than having to go into the open environment. But doing that for more complicated surgery like the esophagectomy, for instance, and for colorectal low anterior resections and so on, when things go wrong, there has to be the ability to go back to maximally invasive or whatever. And we have to really juggle with that safety aspect, and that must not stifle the innovation of developing new techniques and so on, but we have to remember at the end of the day that we have to put the patient first. And that is very different to all the other technological innovation that happens in other environments. With healthcare, the patient is absolutely paramount. And that's the thing that we've got to grapple with.
Agreed. I believe this is probably the most important take-home message from this session, that everything, we mentioned patient-centered care, that everything should revolve around the patient and keep patient safety at the very top of our agenda. Some people may have some hesitations with regards to adapting AI and digital health because they feel that technology may eventually replace the clinician. But actually what we've been saying here is, at the end of the day, if things go south, it's back to us, it's back to the training, it's back to maximally invasive. So we have to be responsible trainers and trainees, and that we need to ensure that it's not just doing the fancy stuff for the robotics, but we need to be trained in every kind of circumstance. So posing the final question, do you think that eventually AI will ever supersede or replace the clinician themselves? What do you think about this?
I think first thing to say is that let's unpack this term AI, because it is a very generic term. It means a lot of different things to a lot of different people, and it means a lot of different things in healthcare. So there is the use of AI, natural language processing, data analytics, and that's there to make mundane administrative tasks more efficient. And that's fine. That's instead of having to write notes, instead of having to look through pages of notes, instead of having to, you can dictate words instead of having to write them. So that natural language processing side of things and data analytics is an important piece. And there will be a million companies here today that will be doing something along those lines. Then there is AI when it comes to surgical technology, which is based on machine learning of computer vision. Completely different. So that is building decision support tools, such as the endoscopy support tool that I showed. So that now is in many hospitals. That's not there telling you that there is, you must do this or you must do that. It is alerting you that there is a change here, go back and look at it again. Is it an adenoma? Is it a cancer? Is it something you can ignore? So that's called decision support. And that's how we're going to see, and that's how we are seeing AI, as you put it, used in surgical technology. And then we're going to see things like early warning systems. So we can create an algorithm that will stop you cutting the ureter. It will identify the ureter, it knows where it is, so the ureter being the tube that connects your kidney to your bladder. It will identify where that is on the screen in real time, and anytime you try and cut it with the scissors, it will cut the machine out. So that's an early warning system and a fail-safe. So this is how the incremental increase of AI will come along, but it's very different in different fields. Again, in radiology or pathology, it's about going through 1,000 chest x-rays to say they're all normal, because someone's got to sit there and do it. So it's efficiency from that side of it. It's about decreasing risk, and it's about being innovative in what we can do. Will it ever replace? Well, no company is ever going to make a system that says, we're taking responsibility. The responsibility will always fall on the clinician or the institution, more likely the clinician. So I don't think AI is going to replace clinicians anytime soon, but it will augment their decision making and make the mundane tasks done quickly where they can concentrate on other things.
And this is ultimately what will help us in actually improving our patient outcomes and becoming better and more efficient. In the last 30 seconds that we have together here, do you want to pass some final remarks on the subjects very quickly?
Just simply put the patient first.
I think we can all agree on that. Put the patient first.
Yeah.
Thank you for your amazing input. It's been a very interesting session. Thank you all for coming here, and thank you to the audience. And we wish you a very pleasant afternoon.